oncoplastic surgeon. I extend my heartfelt gratitude to Dr. Bagaria for generously sharing his time and expertise with us today. A brief introduction I will give to Dr. Amit Bagaria. Dr. Amit Bagaria completed 4 years of residency based on surgical oncology training from Tata Memorial Hospital, Mumbai in July 2018, along with an experience in teaching postgraduate surgeon. In 2018, he trained in Institut de Cancerology Gustave Roussy at France, one of the oldest and largest oncology institute of Europe for learning advanced oncological skills. In 2022, he worked as a fellowship in breast cancer reconstruction with flaps and implants at ISOS International School of Oncoplasty, and in 2021 in breast imaging and Chennai Breast Center. He worked also as a specialist in training for oncoplasty at Federico II University Hospital, Naples, Italy in 2023. This talk will discuss a compelling argument for top scientists and academics to consider establishing their careers in small cities. Also highlight the untapped potential for groundbreaking research and innovation present in Tier 2 cities, which provide greater autonomy, responsibility, and fulfillment. Now I welcome Dr. Bagaria to start his talk. Thank you all being here, and let's make this webinar an enriching and transformative experience for everyone involved. I encourage all of you to actively participate, ask questions, and engage with the alumni speaker. So, Dr. Bagaria, you can please.
Good evening. Good evening, madam. It is such a pleasure to get an opportunity to connect back to my alumni, HBNI. As you know, I have completed my MCH from Tata Memorial Hospital. It was such a great pleasure to get an opportunity to connect to all the esteemed faculties of HBNI, all the administrators, all the management, and all the students who are currently under the HBNI umbrella. So, without much ado, as soon as I got to know about this talk, and as soon as I got an opportunity to speak regarding, as I was told that this talk is about the placement of the new graduates and new PhD students before they start their careers after clearing from Homi Bhabha National University. The first thing that struck to my mind was the letter from Homi Bhabha himself that he wrote to Vikram Sarabhai. As we all know, Homi Bhabha was a bright, brilliant scientist, young mind at that time, who had completed his post-graduation from Cambridge and had come to India after seeing the ravages of the war, and was deeply pained by the condition in which the world was left. Especially pained by what India was facing through when he realized that India was the mercy of the superpowers of this world, and India strongly needed its own technical prowess to show up for the country itself. He changed his mind and wrote to Vikram Sarabhai in his letter that as long as the nation can provide financial support and can proper appreciation for the scientists and workers in the basic fields, it is their own duty to stay in their own country. And he himself changed his mind, and rather than going to a top university in Europe and America, he just stayed back. So when a mind as bright as Homi Bhabha's could decide to stay back in our country, despite having all the world full of his opportunities, and that too 3/4 of a centuries ago, what stops us from today from considering the option of staying back in our home places, if not just our metros, also to our roots and the cities where have been born and brought up, and propose and offer our own services. And well, now coming to today's talk, I have always considered myself as very fortunate to have had the best privilege to start my surgical career from the Apex Institute of India, which is AIIMS New Delhi. Once I had accomplished my MS General Surgery from AIIMS New Delhi, I had the fortunes to step into the hallowed portals of Tata Memorial Hospital, which, as we know, is the mecca of surgical oncology for entire Asian subcontinent. When I got to complete my surgical oncology training here, I moved myself to leading institutes in Paris and then to Naples to learn advanced oncosurgical techniques and reconstructions. So when I was done with my education, all of my family members, including my parents and all my friends, were very sure of the path that I would take. Would most probably be to live and stay in a global capital, if not a metro in India. But with even with all of that around, my path to me was fairly certain because I always thought my pulling and my love and out of my gratitude towards my home place was much more than the allure and the charm of a major metro in this world. So I took the road which was less traveled, and despite all the offers that I could have had, I still wanted to stay back in my place, and that's what I did. So with that in place, sorry, I'm unable to move the slides. Can somebody from technical help me? Hello,
Hello.
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 I'm unable to move the slide. Yeah, it's now. Yeah, thank you.
Yeah, it is.
Yeah. So with all that up in my head, I moved back to a city called Akola, bang here, right in the center of India, as we can see, which is roughly like 250 kilometers from Nagpur and some 500 kilometers from Mumbai. So it's a district place, well connected by railways, a junction, has a good roadways system connectivity, no airport yet, but fair medical facilities were offered when I was here, when I came back here. Uh, Still, we lacked all the advanced diagnostic facilities like PET scan and all of those, but we were having a fair background to start our services here. And Akola was a place for a medical, is a well-known medical center in at least the some 200, 250 kilometers around the region around after Nagpur. So with that background, I started my practice in Akola, and that was all very surprising and new to me. Mostly because I was habituated to such kind of settings where we see, like you see here, all the DMG and the disease groups and the experts sitting around the round table, including the all the stake bearers, like even the patients are involved in the decision making process. Each patient goes through a rigorous analysis by a team of surgeons, medical oncologists, physiotherapists, physicians, radiotherapists, all of them would sit together on each case, have a decision in such a environment, and then come to a decision. But when I came to my place, I realized that we did not have the luxury of all those privileges, and we had to make do with whatever we could, like we can see in this next picture. So we would have our own. We started going and a process of making our own disease management groups or uh, specific surgeon and physician collaborations, which could specifically target the patient benefits. So we started with small victories where we would come together in a meeting, in just in maybe a small meeting room or a chamber, and discuss each patient. And that was how we started to set up our own tumor board in our local place. Which we then realized that even though the beginning was small and very humble, it was not a bad beginning at all, because even with such a small tumor board in place, which was newly and freshly established, we could give a very good quality care to a lot of our patients. If you ask me to put a ballpark figure to it, like at least 80 to 85% of the patients which would come to us with even advanced cancers, we could give them the state of art treatment. Only a handful of few of them we would have to refer to other cities because non-availability of specialized resources like maybe frozen section or PET scan. But everything else we were able to manage fairly well. So when we move to a new city, we usually have three major challenges that bog us. One is the infrastructural considerations. Would the infrastructural support be adequate to take us through? Second is the patient considerations. Would the patient be willing and would we be able to serve the patient with the existing setup? And then the third and also very important is the patient consideration, is the surgeon consideration. About is the surgeon, will the surgeon have a happy and satisfied and fulfilling life in the city where he settles? So we'll walk through a few challenges which you might encounter when you settle yourself in a tier 2 or a tier 3 city rather than moving away from top tier institutes and top tier cities like all the institutes of HBNI we know are in metros. mostly. But when we move out of such ecosystem, there would be challenges that you have to face. So when hospitals or any institutes in tier one cities would be the tertiaries and corporates, but in tier two and three cities, mostly we are still doing with the single specialty hospitals or private nursing homes or even some government medical colleges or the GMCs. So with those facilities in place, we know that the equipments will be fairly limited. However, despite the limitation in the advanced diagnostics and advanced equipments, basic equipments are still available in most tier two and also in tier two and almost tier three cities as well. Although advanced surgical facilities which need support from paramedical equipments like heavy frozen section or PET scan are not or mammotome are not available everywhere, most of the cases we could still do with these limited resources equally as well as we could have otherwise done for them in the larger tertiary institutes. So, for example, if we talk about oncology, the radiation facility is still available in all the tier 1 cities, most of the tier 2 cities, and also in many of the tier 3 cities now. A qualified team is very well available even in tier 2 cities and most of the tier 3 cities nowadays. The medical oncology team, support staff, and are very well now placed in tier 2 cities and are coming up in a big way in tier 3 cities as well. So, but the benefit here is that we have a lot less of bureaucratic hurdles in tier two and tier three cities as compared to the tier one institutes where everything is very guidelined and rigid. Uh, Tier one institutes, once you start moving yourself through, you know that either your personal name or your institute name grows only by internet reviews or advertisements or social medias. But however, when you are in tier two or tier three or a rural place, the strongest indicator of your professional success is your word of mouth publicity. People tell each other, people do talk to each other, and they let each other know about the experience that you have been able to provide them. If you have given them a good time, that's what they'll talk about you, and will have a good word of mouth publicity. And local media is more effective rather than the global media or social media in this scenario. Now, coming to the surgeons' considerations, surgeons, whenever they move out from their institutes, especially if they're moving out from the larger tertiary and apex institute, they would always find it difficult to settle in a place like a tier 2 or tier 3 city because of so many limitations that would be imposed on them. Uh, Also, once they move into the tier 3 city, they realize that all the privileges that they had in the apex institute would not be so easily available. However, they would realize that uh, if they want to start their own practice, it's also not very easy in a tier two setup. It's rather easier in a tier two or three setup rather than a tier one setup. Sorry, that's what I mean. Because tier one setup already has giants sitting established in their own places and doing really good work. So to establish yourself amongst the places which are already doing good work, it's a challenge and also needs more financial background. However, in a tier three setup where there is no challenge and no competition to you growing up, you feel more free when you move to an environment which is not restrictive, rather encouraging of your services. So when you start small, start in tier three cities, it's less expensive and gives you a confidence that you can grow because the usually people around smaller places are more supportive of your growth. However, the liberty in professional decisions that you get in tier one cities, although that leads you to making better decisions in uh, in the restricted framework, you suddenly realize that when you move to your individual practice in tier three cities, that you are the person who's making decisions. So you do not have a lot of resources above you to guide you. So it puts you in a spot, and it makes it necessary for you to research the available guidelines, go through the updated criteria, uh, uh, visit your textbooks again, and find out what is the best for your patient in your given scenario with your limited resources. So these are the challenges that you'll definitely face. With all of these given, it is also notable that once you start doing your work, you'll have a quicker recognition in a smaller place rather than a recognition which is difficult to come by in a larger tier one cities. The smaller cities will offer you a possibility of a leisurely lifestyle where you could be sitting in your hospital at 11 a.m. and then running through a OPD, then operating a case by 1 a.m. or 1 p.m. or 2 p.m., and then having a lunch for yourself, and then move to another hospital in your own city and operate a case there and come back by the evening. But this is might not be possible in the larger cities where the distances are prohibitive, which makes it difficult for you to travel, and makes your lifestyle much more hectic. The income disparity, coming to the income disparity, the if we have a broad overview of it, the top tier surgeons in top tier cities will have a very high income, which would be much in disparity with the income of the surgeons in the same city who are newly established. However, such disparity is not a problem in tier 3 cities or in tier 2 cities, where the apex income is not as high as those for tier 1 cities, but on the flip side, the disparity is not large. So the newer surgeon and the more established surgeons both are making well and good enough for themselves, while also doing their bit for the society. One major downside to living in the tier 2 societies would be that your research opportunities are really limited, and you have some constraints when it comes to your professional growth, because you might not have as many connections or as many associations or collaborations with people who are doing path breaking work in your field. So we'll come to the remedies later, but that's a major problem that you might face when you move to a smaller city. uh, on the other side, although you have a smaller professional network, although you have a smaller social group and a small professional group, your group is more cohesive and everybody knows each other much well, and the collaboration is more streamlined in the smaller cities as compared to the larger cities, where although the groups are large, they are usually not as cohesive. The third and most important are the patient-driven factors that you'd come to. So I have realized in my own personal experience that patients in the smaller setups are usually much more personally grateful to what you do for you as compared to those in the tier one cities or apex institutes. Probably this is because you are able to develop a better personal touch with your patients when you work in a smaller setup, as against in the setups where the responsibilities and the working hours and the working patterns are more distributed, and the patient sees different physicians and different healthcare workers at different time points. Rather, in a smaller city, you are the first point of contact usually, and also you will be along the patient's entire healthcare journey. So they trust you more. They offer themselves better for. They are more compliant to the treatments that you offer. They are less likely to drag you into medical legal issues and lawsuits. Uh, Patient demands are also usually more reasonable in smaller setups. Uh, Although I would not say that it's not a good idea for the patients to have the expectations of the best outcomes in all the cases, but it's also not really possible in all the cases when patients have unreasonable demands that contradict the oncological necessity of the extent of resection and reconstruction. So patients in tier 3 cities and 2 cities and rural areas are more tolerant of the treatment that you offer. Uh, they also have to pay a lot less in the smaller setups as compared to the higher setups, higher cities. And usually the patient satisfaction is driven by the cost. If you are able to give them a very good outcome at a fair cost, they are happy. Whereas in tier 1 cities, the patient outcomes determine the satisfaction is also largely driven by the facility, about the ambience that they are treated in, about the facilities, about the value added services that have been provided. So these might not always be available in smaller cities, but patients in smaller cities would still be appreciative of what you are able to provide them, because they know if they are not able to get those treatments facilities in their own local place, they might never be able to afford them in a remote location, in a location which is far off from their place and in a metro. So when I've analyzed all these three factors, patient, infrastructural, and surgical, and also the India's healthcare facilities and policies, what this is the summary that I could make out of it. So most of the patients that we generate are here in this rural areas and the tier 3 areas, because most of the India lives in villages. So this is where the patients come up. But the problem here is the patients are not very educated or aware about the situation, or in this context about the disease process, or what to do if they notice a lump or a tumor. So they just keep ignoring it, or they just see some quacks, or take unproven therapies of unknown benefits, and that is how they spend their time, waste their time, till the tumor grows to out of proportions before they move up to a tier 3 or a tier 2 city where the treatment options would be better. So once the patient reaches a tier 3 city and a tier 2 city, then either they land up in a proper, well qualified surgical institute, or somewhere which is either totally a quack, or an institute that is not qualified to handle those kind of situations. So in those situations, unless we have a system of referral where the patients from such institutes are referred to where they can be handled in a tier 2 city or in competent tier 3 institutes, the patient wastes their further time and the disease spreads before they become incurable. So such patients out of tier 2 cities, when they complete their treatment, they either go back to their places from where they have come from, or they are referred to a tier 1 city for the treatment. But what happens is that many patients who are not even who don't need a tier 1 treatment also prefer to go to the tier 1 cities because of the lack of infrastructural facility availability in tier 2 and tier 3. So this places an additional large burden on the tier 1 cities, which is the apex institutes, which should ideally be catering to only most of those patients who are referred because they need the facilities in tier 1, or patients who are part of some path-breaking new research, upcoming treatments, modalities, or those who just live there and it's most convenient for them. But rather than serving or treating patients who need or deserve tier 1 treatment, most of the time the facilities and the resources of tier 1 are wasted because the drainage from the rural and tier 2 and tier 3 cities just impounds the tier 1s. So if we can make a robust infrastructural system in tier 2 and tier 3, not only will we free the tier 1 cities for a better focus on research and also a better focus on care of the patients who genuinely need tier 1 treatment, but also will be strengthening our base of this pyramid system, where patients will be able to get themselves treated in tier 3 cities because of the facilities which will be newly made available to them. I know that this needs a lot of political commitment and also bureaucratic shuffle and bureaucratic inputs. But this is what we aim for, and we look for an utopia in India to optimize the tier 1, to develop and educate the tier 2, and fund the tier 2 and tier 3 areas where the facilities can be easily made available. So upon further research, I realized that this is not the problem that ails India alone. Because in 2016, US under the Obama Senate and Biden administration launched a Cancer Moonshot Initiative, which was a multi-billion-dollar initiative to fund treatments looking for magical therapies, or magical I use loosely, but what I mean is ki very high-tech big pharma and data-driven industry where the treatments for cancer would just show up with time. So this initiative was surprisingly praised highly by almost 70 deans and directors of public health institutes in US itself. But with time, it was realized that this billion-dollar project was diverting the funds away from the projects which were already curing the patients who are in curable cancer stages. So this led to an outrage in the same setting, and not far from 2016. In 2018, Lancet again had to publish a major comment, which was the cancer ground shot, which was a cleverly worded rebuttal to the moonshot initiative, which meant that before we go to the moon, let's cure the problems on the hand. Let's become global before going to the moon. What it meant in this context was ki when the patients are most of the patients can be cured and can be treated with proven therapies which already exist. But if we divert a lot of funds away from the therapies that work towards the therapy that might work someday or might have marginal benefits, you are in a way spoiling the demographic and the ecosystem chain balance which has existed. So this was received very well, this cancer groundshot initiative, And then in 2022, Nature came up with a very simple article. The tagline was as simple as cancer treatment should benefit a patient. That and that was termed as a common sense revolution in oncology. I know it sounds very fascinating that the journal, as respected Nature, would have to come up with an article that sounds so logical and so bare minimum that cancer treatment should benefit the patient. But that was the need of the time, because the were going in a place, the funding were going in a place which were diverting the much needed funds from the already resource deprived areas to the resource abundant areas, and pumping them into areas which were not benefiting the masses. So that is not necessarily a wrong intervention, but at least it should be paralleled with a more robust ground shot initiative, which would take care of the masses before going big on data or newer technologies. So I would like to read this verbatim. What Nature Medicine has written is that when cancer patients are dying due to lack of access to basic life-saving proven surgical interventions, a new cancer drug that marginally and might even just possibly extend survival is not going to solve a problem. So that is the common sense revolution that we had looked for. As long as we continue to rush ourselves into the latest or into the most upcoming or into the most novel and the most pressing problems of the urban and the most upstream areas, we are not going to look into the problems that exist in the ground, in the grassroots levels. So that is where we need to get the change started. So the Greeks had called it as non schola sed vitae. That means whatever we learn for our lives. We don't learn for our textbooks, because these textbooks, the guidelines that they prescribe, were written in the global capitals and not in your surroundings and not in our neighborhoods. So when we try to replicate those models which are written in, let's say, Geneva or London or New York, in a tier 3 city in India, we would fail miserably, and we would not be able to do what we could have otherwise done with our own logical understanding of resource adapted guidelines to our settings. So that those are not for us to blindly be followed. Those are meant for us to come up with our own modifications for our local situations. And our local scenarios will only change when the think tank from pioneering institutes and apex institutes like HBNI, the institutes under Homi Bhabha National Institute like Tata Memorial or other science institutes, when the bright minds from these institutes will start percolating in the distal most cities of India, that is when I suppose we'll have a change. That is when I suppose there'll be a different tomorrow for India, because we do not, we, it's not always the most novel problem or the most pressing problem or the most recent or the urgent problem that needs as much attention as the problems that have been existing for decades. Like most treatable cancers are existing for decades in these areas, but they just die when they could have been saved with a smaller investment of capital, with a smaller intervention from all the think tanks and brilliant minds and brilliant doctors who are oversaturated in the metros. If few of us in these areas, we would be able to make a change which is much larger than what the moonshot would ever make. We just make ourselves so much involved into the recent happenings that we lose track of what lies beneath the epidemic that lies beneath. We forget that in our places, it's not the patients who are dying are not dying because they missed a screening test. They're not dying because they missed a single visit to the regular physician, but they're dying because they have a tumor which is fungated that it needs a proper medical attention till it has maggots in it, or it was fungating, or it was bleeding. So we are fighting. These are local problems. These needs local solutions, which needs local people to be out there amongst the public, amongst their own people, talking to them, getting an idea of what's ailing them, and then coming up with the solutions that they think would help their own people. In theory and practice are same, but in practice, theory is not the same as practice. This is what we all know, and this is all what we have to replicate in our working. So these are the kinds of patients that you would rather see in an oncology setup of a metro or a larger place, where there, of course, a lot of larger tumors would also come there, but people who are aware and living in the metro and are surrounded by people who are aware and are surrounded by good medical facilities would usually also present in such smaller tumors where they would be easily resectable and the challenge would not be as large as the people uh, who are sitting in tertiary care in the smaller setups. And we often see patients like these who wait till the disease fungates, it has maggots and stinks till seeking a proper treatment, because most of the time they just wait for some fake quack treatments, or just because they think it will go away or it is the wrath of gods or something, but they'll never seek treatment. So this is our challenge. Similarly, these are the kinds of early tumors that we'd see in a setup, or in a good corporate setup in a tertiary center, where people are well affording, well educated, well aware, and would present when they just realize a small, barely perceptible change in the breast. But in peripheral centers, these are the kinds of growth that we see not, and it's not very unusual to see any of these. Uh, every few days, we'll have one lady who walks up with this or similar cases. So these are the challenges that we have to look through. These patients waste their time in all these places. Well, they'll be promised some magical cures. They'll say that you just have this potion 2 times a day, but take 2 bottles of this potion. It's a cancer-specific treatment. They go to whatever quack polish promises them the biggest results, and then wait for months till it becomes incurable. So, but the joy here is that when you settle in this position, such places, it was not, the patients were not seeking treatment. And once you go there, and once you see your society, and once you intervene, once you talk to them, you realize that if you have trained in places like Homi Baba now already, you know you are capable of offering them the world class services in their own place. So when I've moved to this city and I started offering major resections and reconstructions to people in my own places, so they could come to me and they could still have all the major surgeries that they would have otherwise had in the topmost institutes like Tata in their own local place. Of course, not all the surgeries, but at least 85% of the cancers that we see, I'm able to manage in my own setup here in a tier 3 setup. So that is how the society would that is how you would be able to be an instrument of change in your society. Uh, the benefits of breast conservation, breast reconstructions, which were otherwise just limited to the to Mumbai, Delhi, Chennai, Bangalore, and such cities in India. Uh, I could provide to my people in Akola and nearby districts of Vidarbha, which is otherwise considered to be a backward region. But with these results in a smaller place, the patient gratitude is immeasurable. Of course, this does not come without its own challenges. Uh, there is the challenges, the major challenge being that about patients' awareness. They are not aware about the disease. They have to pay out of pocket, unless either out of pocket or just in whatever the government yojanas and scheme would cover. Uh, you do not have a set multidisciplinary team in your backup when you move to these places. You have to start from the grounds up. You have to build your own team. You have to check for the availability of the resources and the facilities, and then uh, allocate the logistics with the limited resources for your own patient's benefit. You are ultimately trying to build castles for the people who are unable to build their own shelters and provide pastry to the people who are unable to afford bread. I know this can be frustrating, it can be difficult, but it's not difficult or frustrating for no reason at all. These challenges also have their own remedies. Once you get a good mentor or good collaborations in your own places, when you keep your strong ties with your own alma mater, you keep your ties with your colleagues, your seniors, your juniors who have settled elsewhere, with those systems in place. Also now you have internet, you have high speed access to all the remedies that exist anywhere. With that and collaboration and telemedicine and conferences and securing government funding and starting research projects in your own place, you can create a revolution to whatever scale you can in your own place. And this is not impossible. Of course, this once you are into it, you this is what I have realized for myself when I was here. Uh, it gives me joy. It gives me happiness to get a connection with the patients that you treat. The gratitude that patients give you is one of the biggest rewards that no monetary rewards can often ever match. You feel like you are making a difference in the undeserved, underserved areas. You feel you have a personal touch with the patient. You feel the connection. You feel the joy of serving your own people. And the people would reciprocate, they'd realize your intentions. As long as you do it with the right intent, they would be accepting of the outcomes, despite the limitations in your resources. Uh, but again, the if those were the joys, there are sorrows. The sorrows is the finances might be limited. You might have limited research facilities. You might not be able to access a lot of research institutes as frequently as you'd want to. The patient's misery, the fungating tumors, the incurable diseases, the patients who cannot afford treatments, the patient who would be dying in a few months because of the treatment that they have ignored. All this would bring you immense sorrow. But then also, this is the point of your existence, our existence as people, uh, as people who serve in the social sector. We have to find a right balance between the joys that our services will give us and the sorrow that our services might bring. So as long as you are doing it with the right intent, you have your empathy, but you are detached from the outcome. Detachment as so in so much as you do not get personally affected by the uh, amount of ignorance around you, but you strive to change that situation for yourself and for your people. That is your effort, that is your empathy, but also with a detachment from the results, because single-handedly, I understand none of us can make a difference, but together we can. So as long as we practice detachment with empathy, practicing our craft would become a meditation and a spiritual exercise in itself. Once we are capable of doing that, there's nothing that should be able to hold us back from being able to bring out a change in our local society. Once you move to your own place, you can then ignite more younger minds in your place, in your societies around you, to replicate what you have done. There'll be an inspiring example to them, so that they want uh, to come back to their place and serve their societies and their people. Thank you very much. Hello. Hello.
Thank you, Amit, Dr. Amit Bagadia.
Thank you very much.
Very informative talk. Any
You.
question from the audience here? Any question? Students can ask any question. Any question from the online? There is a question.
Hello. Yes, we
Sunny,
can take the questions.
Sunny. There's a one person has a hand. Samu, Mr. Hello?
Yes, we can take the questions now.
Yeah, yeah. Mr. Mr. Samu. You unmute her. Huh? Hello?
Yes.
You can type the question.
Hello, sir. Question is in the chat box. You can stop sharing and screen and see.
Yeah, just a minute.
Question in the chat box.
Right, I can see. So we have a question from Sanu, which is, can interdisciplinary make a difference in the way cancer can be treated? Yes, definitely, most definitely. It's one of the strongest interventions that uh, it's a very strong recommendation that whenever possible, a single case of cancer should be treated by a multidisciplinary team, because that gives a holistic approach towards the treatment journey of the patient. So once every patient is seen by a medical oncologist, a competent surgical oncologist, a radiotherapist, a radiologist if need be, a radio diagnostics, theragnostics person if need be. So as much as all the facilities that are available and as many experts are available, that is the kind of brainstorming sessions. So basically, these interdisciplinary meets or the disease management DMG group meets, as we would call it in Tata Memorial, are the cornerstone, are on which the leading outcomes that Tata can generate are based upon. Because every patient gets inputs from all the stakeholders in the team of treating healthcare physicians. So if a medical oncologist has some concerns about the patient, if and if they fall in the domain of surgical oncologist, he's always there to provide his inputs. If there are some doubts about the imaging of the patient, there would always be a radiologist who can guide and clear the confusions. If there is some discrepancy in the treatment pathway that is suggested by one of the surgeons or one of the physicians, it can always be accommodated and improved by a generous discussion and very and the inputs of all the fields. So yeah, interdisciplinary teams do make a difference as long as they are available in your place. And if they are not available in your place, they can always be set up. There can always be a starting and an initiation for them.
Thank you, Dr. Amit.
Thank you.
Any more question from online? Another question in the
So
chat
we
box.
have another question from Vyom Neeraj. I'm in the first year of integrated MSc at NICER Bhubaneswar. I wish to pursue my career in cancer research. I tried for internship, but I still can't fulfill the prerequisite. I tried at ACTRIC. Can you please suggest what's the best skills related to cancer which can make stand alone amongst applicants? So I'm really sorry. I'm not aware of what makes your application stand out uh, in a research setup, because I have a very limited research experience. Although I have worked in ACTREC in the RNA labs for a month during my during my post graduation days, but I do not really have my good input or an answer for this. But I'm sure a lot of people in the university room there might be able to take this question. So if anyone can take this question, please.
Regarding, so this is internship in ACTREC. Okay. Mm. Yeah, yeah. But he told that he has applied already, but he didn't get.
So I suppose you would be able to get better guidance from people who are already into the program. So maybe you can
Write
try
to
connecting
me
them
and
on the
if you
professional
want,
networks.
I
Yeah.
can guide you to write to. There is Dr. Prasanna Venkatraman who can maybe can guide you. So you can send your application. I will try my best to guide you. Yeah.
So yeah, we have another question. I'm a physics student working on supermagnetic iron oxide for the theranostics of tumor. So it's a new research idea which has motivated me to go for it rather than going for the proven life-saving interventions. So there is a need to go for new and better. Of course, I totally agree with you. There is definitely a need for advancing our knowledge. I'm not. Uh, the message of my talk is not that we should not go for the moonshot. Definitely, that is what we have to look forward. That is where the future lies. So I have no intention of claiming or not even suggesting that it's not right to invest our own selves, our efforts, our resources into out of the box ideas. It is definitely where the future is. The idea of my talk is only that we should not forget the ground shot while we are looking at the moon, because the amount of resources that a ground shot takes is far less, and it can serve a lot more people than the same amount of resources when spent in therapies that are coming up. But there has to be a balance in both of us. We cannot ignore the problems that exist on ground while we are working on a future. We cannot ignore the present. So I really appreciate your work on the supermagnetic iron oxides. But and there is in no way I would like to discourage any new research and interventions. I'm all for it. It's just that we have to have a parallel intervention with adequate funding on the ground and the grassroots as well. So, and thank you for the great work that you're doing in the supermagnetic iron oxide fields. Thank you.
There is a question from here, audience. Hello.
Yes.
I want to ask, which is
Yeah.
the most challenging cancer
Uh,
for treatment? I know that stage is what matters a lot,
mhm.
but different types which we see out of that, which is most challenging as a doctor, as an
Uh,
oncologist.
So there is no one answer to this. There is no one cancer which is most challenging. Uh, I see what place your question comes from, but there is really no single answer to it because each cancer can take its own course, and every cancer is different. Although we label the diagnosis as either, even if we talk of breast cancer, no two breast cancers are the same. Even if we match them from the stage, let's say some patient who's in stage 2 breast cancer might not is not exactly same as another patient who is in stage 2 of breast cancer. So across, if there is so much of heterogeneity in the same tumor, there is no way we'll be able to compare uh, demographics of one tumor as compared to some other patient who has another tumor. So there is no one answer because cancer is a very heterogeneous disease, and now with as more and more work is coming up from and a lot of it is coming from ACTRIC, where tumor heterogeneity is being studied, tumor microenvironment is being studied, the tumor growth factors are being studied, where uh, they're coming up with causes that might differentiate one tumor from another tumor, although they're the same disease stage. So with all that coming up, there is no single way in which we can quantify one cancer as more difficult to treat than some other cancer.
That's correct. But brain and location in brain and growth rate, cell growth
Yeah.
rate, everything matters
So
a
that,
lot.
yeah, so those are the factors. The growth, like you pointed out yourself, growth rate of the tumor. No two tumors will have the same growth rate. Even though they might have the same diagnosis, they might have the same histopathological look under the microscope. The growth rate might still be different. And even if the growth rate is not even the single and the only factors that is considered, because a tumor with a higher growth rate in a person whose general condition is well preserved will not be as rapid in the patient's decline as the same tumor in the patient who's already bedridden. So
Oh,
with
yes.
so many factors going on around, and also a bedridden patient in a remote location might not have as good as outcomes as a person with the same tumor who is doing well and healthy, but in a setup where he has abundant resources. So there is no
Yes.
one scientific way to come to an answer
Yes,
to that question.
that's correct, doctor. Thank you. Thank
Yeah,
you.
thank you. So we have another question with Mr. Ravi, Dr. Ravi. Uh, I'm MBBS intern from GMC Aurangabad in Maharashtra and preparing for MLE. And then I was just wondering the difference between research opportunities between foreign medical institutes in Europe or USA, and then difference between our tier 1 and tier 2 cities. So what I suppose is that there definitely is a difference in research opportunities that we have at present in our place and the opportunities that exist elsewhere. But if you, I suppose that I'm not the best person to answer this, because somebody who's already working in a research sector, like a lot of our esteemed faculties sitting there in the HBNI hall, I suppose they would be better able to guide you, because the research opportunities that are available in ACTREC, for what I know, are world class, and that comes in our HBNI fold itself. So I don't know if what specific but what I can suggest is that you pinpoint your area of research, what research you want to do, and once you have pointed out what research you want, and then you can explore the labs that are cutting on the cutting edge of the research. It is quite possible that the things that you want to look for and the things that you want to research have their own cutting edge labs in our own settings. If not, then you can always apply to one of those ones that are abroad. But you'll have to come up with what you are interested, and then retrospectively go behind and look for what are the people, who are the people doing it.
Hello, there is another question that is from YouTube, no?
Yes.
So
So-
that is from YouTube. So beyond city, there is a
So there's, yeah, how to proceed for ethical issues which come up as a challenge to a researcher like me. So ethical issues,
Okay.
I'm sorry, I'm not able to answer your core research field questions because I'm far removed from the research field. I only have some idea about medical research, but not the core research. For medical research, I can tell you. For medical research, what we do for such things is we have our own institutional ethical institute ethic committees which have the regular meetings. So whenever we come up with a medical trial or a proposal or a new intervention or a therapy or a modified surgery or something intervention that has not been done before, we register them with our institutional ethics board, and then it gets reviewed by the review committee, and then we only start intervening when we get a ethical clearance. So just what I suppose it would be similar for the researchers as well. Beyond tier 3 cities, there is less oncology centers. So this another question. Beyond tier 3 cities, there is less oncology centers. Poor patients are not able to afford the cost in tier 3 cities. What is your comment? Poor patients from villages. Yeah, that is a very pertinent question. But in the places where I'm practicing in Maharashtra, there is a very wide coverage of government yojnas and government schemes that which would provide almost a universal coverage for the most of the cancers that we see in our places. So patients who are not even able to afford two meals a day can afford a cancer treatment with these government yojnas. And although the financing of these yojnas for the institutes and for the doctors is not very alluring, but the patient outcomes that a good qualified center which provides access to yojnas can give to the patient is really life changing. And uh, a patient who slept hungry the last night because of not getting meals is getting state of the art treatment in such places with those interventions. So yeah, being poor is no more an excuse for not getting a treatment, and that is I tell a lot of my patients in OPD, because when I ask them, why did you not come to us before your tumor did ulcerate or fungate or just blowed out? So they always bring up the reason that they come from an impoverished background, and then I tell them, you do not need to shell a penny when you come with those government yojnas. You could have known better and you should have taken the advantages. But anyways, for I just ask them to percolate this message to their neighborhoods that with all those government schemes, it is virtually free of cost for the non-affording patients.
Yes, this is also another question, but
Yeah.
from me that how these yojanas is people know, that is the thing, because people may not be aware of this also yojanas, because I sometimes the thing.
These yojnas are advertised by the media, also by the print and the media, and also by the television media. And also there would be a lot of hospitals which would be running these programs. They would be regularly conducting the drives to involve these patients who could benefit from the yojnas, because ultimately those are the numbers that the hospital is generating. So the more the patients get enrolled in those yojnas, the more would be their patient database. The more would be their patient ground base to serve to. And also, once the patients become aware of these facilities, the word spreads really fast, because it changes their lives. It saves their lives. Unaffording patients can get the best of the treatments. So it does make a difference.
There is another question in the chat box. I can see.
Yes. So there is
As a
question.
doctor.
As a doctor, what are your views on AI on collaborating with healthcare, like medical image analysis? So that's a good question. AI definitely, I suppose, is the future, is the tomorrow that we are going to look at. It might not totally replace, probably it won't replace expert opinion and an expert uh, uh, skill, like performing a complex surgery or making a complex judgment about patient treatment charts. But it would definitely help in coming to an informed decision. It might help the patient articulate themselves well. They would be able to research their uh, findings better. As doctors, we might be able to someday take help of AIs in uh, coming to better treatment plan than what we have decided. And specifically, like if you ask medical image analysis, there's a lot of work being done where machines are being trained to read simpler imaging modalities like a chest X-ray. So they have done a lot of research where human verified, as in radiologist verified X-rays were shown to the machines, and the machine outcomes were compared to the outcomes that were given by qualified radiologists. And with the improvement in the AI technologies and imaging modalities, the machines are coming closer and closer to the opinions that have been generated by trained radiologists. So we just hope that someday we'll have a future where AI would be as competent as trained doctors, and we would be able to make away with the shortage of doctors in our situation and a scenario. But that might be a distant future or not at all. I'm not sure.
Any question from audience?
Yes.
Hi, sir. I'm
Hello.
a student here. So I wanted to ask if, as a researcher, I can join clinical research.
I suppose when I for a month I had worked during my MS training when I was in the AIMS Delhi. I had come to ACTREC for a month, and I can only speak from those insights. What was my idea of that was there is a huge gap between what the doctor is doing on the bedside and what a researcher is doing in the labs. So it's a very flimsy bridge which people are not willing to cross often, because the clinician is so absorbed in what he's doing in the clinics, and the researcher is so absorbed in what he's doing in the labs, that barely do they find time to see how has the research that they are doing changed what is being done. Or doctors are unable to spare time to find out for what drug, for example, the interventionals or the chemotherapy agents that we are using. We have no idea of how they were developed, or processes that go through in the making, or how they are being tested in the labs. So this is a very crucial area which I would also request, now that we have the privilege of having the staff and the faculty and the management and administration of the university around. I would urge them, exhort them to find some way in which the clinicians get more time in the labs, and the scientists get more times in the clinic where they actually see what the patients are suffering from, so that they come to know that the medicines that they're making in labs are not going to the lab rats. They're going to real people. They're changing real lives. Every every research, every intervention that they're doing, even on its preclinical stage, is ultimately going to the clinics. So they would have a more human touch to their research, and might even change their ideas about research. And this would serve the clinicians also well, would have a good two-way communication between the labs and the clinics. So if there is some way we can get a stronger communication between the labs and the hospitals, nothing like it.
Another question?
Hello, sir. I'm a
Yes, hello.
student here in BARC, and my research work is basically on radio protectors. So it's like when we have a
Protectors, right.
combination. Yeah, so combination of radiotherapy and surgery. So
Right.
the normal cells will also get affected, right, with the radiotherapy. So we use a radio
Yeah.
protector. So I would like
Yeah.
to ask, what are the radio protectors that you actually are using in your clinical practice? Is there any radio protector or agent that you use as such in your clinical practice? Thank you.
Thank you. Radio protectors, mostly it's with the newer machines and modalities coming up, we are seeing less and less of the radiotherapy side effects. Like in the days when the cobalt was the only and the major option, everybody would have a lot of skin reactions, a lot of collateral damage to the tissues, which was not intended or the target. So with as we get better and more targeted, for example, with image guided, intensity guided, gated radiation delivery techniques, or also the most advanced, the stereotactic therapies. With all of those, with cyber knives and all, we are able to pinpoint and precisely target and focus and kill only the cells that we want to, minimizing the collateral damage. So that is the most important way in which we protect our patients from the damage of the radiotherapy. Although there are other chemotherapeutic agents, radiation, radio protection, but these are I have not used a lot of them personally because I'm not involved in planning the radiation fields and immediate care of radiotherapy patients. I mostly restrict myself to my surgical oncology practice, but we do see a lot of patients who have radiotherapy side effects, and you do good service to all of them if you come up with agents that would protect all those skin reactions and the side effects that radiations does bring. So I would also request you and exhort you to visit your radiotherapy wards and see what kind of skin rashes and what reactions the patient who are really actively undergoing radiation face. A lot of those side effects, although they're not spoken about as much as they should be, but they're really debilitating for the patient. For example, after a major surgery like a mandibular resection, a patient would get a radiotherapy, which is fairly common. But a patient who has lost an important part like mandible would hardly talk about dryness of mouth, which would be a side effect of radiation due to the effect on salivary cells. So these are patients who are not even vocalizing what they're suffering. They're not even letting you know about what they're suffering because they know that they have bigger problems to face, and they know that as a doctor you are looking at bigger problems. So they choose to ignore more often than they should about such problems which they then deem as more of inconveniences rather than problems that they should face. So these small problems like dryness of mouth makes it difficult for them to eat, difficult for them to get the taste of the food they're eating. So yes, these are problems that you can really visit the ward and find out in first person for yourself.
Any other more question? There is another question in the chat box. I can see
Yeah.
detecting cancer at the
Detecting
early stage,
cancer.
at the early stage is still challenging. Even educated people die due to the diagnosis, due to late diagnosis,
Yeah. So
in
that's
spite
true.
of the modern diagnostic facilities.
That's true. That's very true. And that is the sad state of affairs that we are talking about. So the only treatment for this is education and awareness. We can't emphasize this more. The cheapest and the best and the most successful intervention that can consistently save lives of cancer patients is not the newest anti-cancer or the immunotherapy or the targeted agents. The cheapest and the best and the most proven agent that would rather save most of the lives is education and awareness, where patient himself knows that there is something get to his physician with. If the patient is aware and he comes for the treatment in the preclinical or just the early clinical stages, he'll surely have a better outcome than the best treatment that you offer them at a later stage. So that is why I always say that education is the best investment for creating a healthier oncology milieu in our country.
Good evening, sir. What are
Hello,
your
good evening.
views on rehabilitation and improvement of quality of life of patients after oncosurgery?
That's a very important and often neglected aspect of oncosurgery because the patients just subscribe themselves to the misery that is the aftermath of a major resection or a debilitating or cancer treatment. It's very important that these patients know that rehabilitation facilities exist. There are occupational therapists, physiotherapists, rehabilitation experts who can take the patient back to a normal or patients. Take the same example, a patient who has undergone a major mandibular resection. They find difficult to do things as easy as swallowing, as easy as talking. They are vocal because the geometry of their oral cavity has changed. They are unable to vocalize what they want, what they need, what they can do or can offer to the family. But that should not stop them from being able to be a productive member of the society itself. इसी के लिए जरूरी है कि patient should be aware of all those rehabilitational facilities that are available to them. We have a very robust department of physiotherapy, rehabilitational services, occupational therapy, physiotherapy in Tata Hospital as well, and they are very also a PMNR department which is actively involved in rehabilitating patients with disabilities. So patients must be strongly encouraged to seek part and seek training with these therapists who will be able to put back the patient to as normal life as possible for him.
Thank you, Dr. Amit.
Yeah.
Any other question in the chat box? Any other question in YouTube? And there is some, you see, and Dr. Ravi.
Yeah, we see a hand there.
Hello, ma'am. I was just asking, like, in our medical setup, in our medical college, we see a lot of lifestyle diseases. Primarily, we are seeing lifestyle diseases like using alcohol and all that. So they primarily are affecting the cardiology part, like heart disease and all. And then currently we are seeing the technology like the smartwatch and all that, so which primarily monitor the pulse rate and heart rate, and even can alarm if there is a go if they find something goes wrong or like that. But I think with the green revolution also we are using a lot of pesticides, and we will see that like in oncology many of the cancers might be and due to the lot of urea and a lot of pesticides being used on the in our crops like that. So but no one is talking about that, so I want to ask like how you see if we can prevent cancer at the first place, and by changing the food we cannot change the food, and we also seeing our economy we cannot directly shift to the organic part, but how you see like how we can educate people about that, and like for the cardio disease we can say improve your lifestyle, do regular exercise, you can avoid that to this large extent, but in case of
Yeah.
oncology how we can do that?
I see where the question is. So it's a really good question, because every day you just pick up a random newspaper and you'll have at least one article that says that such and such institute has discovered that such and such food item has chemicals that are carcinogenic. Just like last week, the news was inundated with carcinogens in some specific masalas and chaats. They are just all around us, and they have been around us for quite some time now. It is just recently that we are coming to realize about what side effect each of those chemicals has on a long run, because cancer is not a disease which would be which is like a switch. If you inhale a toxic fume, or you eat a carcinogen, or you come in contact with some other agent that is known to cause cancer, you will see a result in a day or two. So it's really difficult for the studies and the researchers to put up a proper association and causation between them. As we know that association is not causation. We might be able to associate a lot of things with a lot of diseases, but we do not know if they really cause it. Although we strongly suspect that a lot of these cancers will be caused by all of those chemicals that we have spoken of, it's difficult to pinpoint what exact chemical has caused what kind of cancer. Although it's fairly known that a lot of them are causative factors, but it's also difficult to eliminate all of them, because they're now with modern lifestyle, they're part of our everyday living. You cannot totally eliminate food that has been grown with modern fertilizer and farming techniques. You cannot, like you said yourself, we cannot all shift to organic food just in a span of a few days or a months or years, because that's healthy. So we are still trying to reconcile with that problem. How can we keep ourselves safe from all these agents which we don't even know are carcinogenic? Because every other day we realize a new agent which might be carcinogenic as well. So there is no way to do it. Although the most often way that I suggest is that which you can do is keep yourself clear of the most common carcinogens. For example, tobacco. So if you keep yourself clear of tobacco habits, chewing, smoking, and all of those, you'd be saving yourself from a lot of cancers that we know happen with tobacco. Although you cannot definitely do this for every other article in your food, but you can only do as much. Maybe you can improve your eating habits. You can avoid a lot of junk. You can keep yourself and try to find yourself for healthy, organically grown food, but that might not always be possible, but you can stick to as much as possible. You can start a healthy exercise habit, because we know that exercises, regular exercise, a healthy diet are instrumental in keeping our immunity regulated and keeping, which also in turn checks the development of malignancies in our body. So with so many unknowns around, where we do not even know on what strategies to focus, it is better to at least focus on what we can, rather than waiting for interventions to come for the things that are not known, like what spices have what masalas, or what chemicals in your pesticide have caused what kind of tumors. We can at least eliminate the things that we know. For example, tobacco. Keep a healthy lifestyle, keep a good diet, exercise well, uh, keep in good contact and touch with a physician if you see there is any early sign. So these are the things that we can do and we should do. But your question is an open question, and there is a lot of research going on to find out all the carcinogens in and around us.
Thank you.
Thank you.
Any other question from the audience here? Any other question? So, thank you, Amit, for such a informative talk. I am sure that though there is not lot of participants, but it will be afterwards. It will be seen by all the in YouTube. Your talk will be available, so people can look into your talk, and they can get benefited. I am sure that your talk will also help all the oncology students and researchers and oncology surgeon. Not only that, your researchers and life science and chemists also. I'm very much happy to see that you are really explained that why people should go to Tier 2 cities and their scenario there. And I am very much thankful that you have agreed for this talk in this HBNI. And thank you very much.
Thank you.
Thank you. And
Thank you for having me with all of you in HBNI. It was glad to be a part of my alma mater again. Thank you very much. It was a
I hope
pleasure.
it will all help you that all for the placement of all the oncologists also. So
Yeah,
thank
of
you.
course. Thank you very much.
Thank you.